All right, so where do you guys want to start? So I'll kind of put something together here. I mean, kind of start listing topics, right? But tell me where you want to start. Got some CAD, some CHF. All right, where do you want to start? These are all our topics, right?
That was
Say again?
ASCVD.
ASCVD, top one? Is that the one?
Yes.
All right, so tell me where you bring your questions, let me know what you have, and I mean, I'll just start talking about it, but I want to make sure this is your time too. So if there's something like, oh, I know that, just let me know and we'll go on to something else. So you just want me to start talking about it, or what do you want? What's specific about ASCVD? It's gonna be a very short review session.
It can cause ACD.
It can cause
Sorry,
what?
CAD. It can cause CAD. Sorry.
Yeah, so if you want to look like complications over here, so I think of things in tables. Something else might work better for you. All right, so we'll go for like general stuff, right? Causes, we got signs and symptoms, and you can even put another column for diagnostic tests, insert column to the right, or okay, for sure. All right, so diagnostic tests, we got signs and symptoms, complications, and nursing stuff, right? Nursing interventions. But before we have complications, we have to treat it, hopefully. All right, so treatment, okay? And then, so complications, yeah, CAD's on there, right? So is a lot of other stuff. Hypertension is there, okay? Diabetes causes ASCVD, so does hypertension cause ASCVD, okay? It's a catch-22. Okay, so do you want to, and then treatment, we got non-pharm. This is for every disease process ever. You have non-pharm, pharmacological, and surgical, right? There's really no surgical treatment for ASCVD, but just so you know. All right, so pharmacological, that's going to be all our meds, right? That's going to be your statins, and I said statins because statins are like usually the most important thing, right? You got statins, other stuff in there too. Okay, non-pharmacological is kind of overlapping with nursing interventions, all right? Because nursing interventions, we're going to be teaching what? What do we teach for ASCVD?
Quit smoking.
Yeah, it's your ABCs, right? D, E, and we added an E for hypertension and for ETOH, right? But that's pretty much applicable to every ASCVD complication, whether it be CAD, CHF, and down here PAD. We're teaching ABCDs, so you really want to know that because it hits pretty much like 4 disease processes. All right, so you want to know all the intricacies of the ABCs, right? And if you want to make your tables nice and lean, so you can put another one down here, a teaching table, okay? And this will be our ABCs, right? If you wanted to go in depth about your what to do with those, right? So here are my ABCs. A, B, C, C, D, D, E, E. Right? So what's my first A?
Aspirin.
Good. So aspirin. What do you need to know about aspirin? It's low dose, and it's what? Every day, right? Given for those at high risk. Not everyone, right? And what is high risk? Just basically someone who has an ASCVD event, a complication. Oops. Well, that was easy. I didn't know you could do that. Okay. Insert one column to the right. Yeah, so high risk, not everyone, just those who have ASCVD complications. Or DM, for instance. And you put your other A for aspirin stuff. right? What's B? You can make this look pretty and put little
Blood pressure.
little points and stuff. Yeah, B for blood pressure. And what do you gotta know about blood pressure?
You want them to keep it under 130 over 80.
130 over 80, right? And then what's C? You got two options for C.
Cholesterol.
Cholesterol, right? And what do you have to know about cholesterol? You have to know your normal labs, right? Keep it good, keep it normal. So keep normal labs. We gave you two different values for your lipids, right? Or actually for LDLs, but everything else pretty much you want to keep it under, keep normal targets, and LDL less than 70, right? That's what we want for all of our ABCD teaching. We want that for CHF, for PAD. We want the LDL under 70. That's going to prevent further complications such as these guys up here if we complete our list, right? So instead of keep making this too detailed, we can make another table just for lipids, for ASCVD labs, right? That were being complete. Let's put our chart here. Nope, I want a table. And some unique things about it, right? So you got triglycerides, you got cholesterol, you got HDLs, LDLs. What else? Is that it, right? Anything else that might come up along the way that we mentioned as far as ASCVD labs, right? So you can put normal and other stuff, right? Other things you might want to mention. That way we know keep normal. So LDL is if ASCVD risk factors or complications under 70, right? Otherwise, normal is what? Did I say 130? What did I tell you? 130, 100? Something, okay? So you put it there. Put your other normals in there as well. And any other useful facts you want to know about these things. And if you don't know what TG means, just go ahead and put triglycerides, all right? All right, let me know if I'm going over things that you already know, so we can, where do you want to go back to? Or are you done with ASCVD? Do you just want to keep going, teaching?
I don't know.
We're good on ASCVD? Yeah? Thumbs up?
Yeah.
All right, so this is nice because this is going to duplicate for all of our stuff. Instead of duplicating and making my study tools so many pages long, this will be, I just reference it up here. Whenever I say ABCDE teaching, there it is, right? And whatever other teaching we mentioned to you for as far as like diet, for instance. Well, actually diet would be over here. And pretty much the diet is the same recommendation for every patient, except for like hypertension. It has some unique things we do for hypertension. So what's different for hypertension versus ASCVD? Well, what's the difference in diets? I mean, it's not going to hurt.
Control, sodium control.
Well, sodium's for both, but I mean, I guess if you just have fats, I guess you could splurge on sodium, but it's another electrolyte that you want to be looking out for. High potassium diets. That's really just only hypertension, high potassium diet. But low sodium diet for hypertension, low sodium diet for CHF, yeah, low sodium for ASCVD is not going to hurt. But you want to know, kind of recognize the differences, right? And the differences are the ones that get tested on. That's because that's easy to test on, right? And the other way to test on it is do a SATA and say which one of these diseases have this diet, but it's easier to test as far as the exceptions to the rule, exceptions to these things. And of course, life-threatening things. Things are life-threatening, and medication-wise, what are your life-threatening complications or side effects? What medications do you give with medications to make them work, right? Which one is that? Which one of our ASCVD meds do you have to give a medication to prevent side effects? Which one's that? Got fibrates, we got niacin, we got eculizumab. The nice thing about Google Chat or Google Docs, if you misspelled it, that's what I meant. All these little terms. So which one of those requires another medication to prevent complications or prevent side effects and help you help the patient stay compliant with the medication? Is somebody muted or just don't know?
I don't think we know. Can you please help us?
Yeah, so niacin is, let me know if you don't know. You feel free to chime in. Yeah, so niacin is the one you have to take aspirin with, right? To prevent what side effect?
Flushing.
Flushing.
Right? You take aspirin beforehand so that you don't get flushing, right? So that's going to be something that will improve compliance. If we know that they are taking their medication and they're complaining of flushing, it's like, well, you should be taking aspirin beforehand. And they should be taking aspirin anyways, right? That's our treatment, right? Aspirin, so we're doing statins, right? And aspirin, usually if high risk, right? Or complications. And then complications, that's a good select all that apply because you have all kinds of stuff. CVA, CKD. We'll get into these ones in the coming weeks, but all of that's kind of related, right? What other complications do you have for ASCVD?
PAD?
BAD, good. PAD, also CHF for that matter, right? Because CHF, all these things, hypertension leads to CHF, CAD leads to CHF, so we can kind of include it in there. Okay, a good static question is teaching. Which one of these are correct, right? For exercise, how much exercise do we need? For E2H, how much E2H can they drink? For diabetes, how much should their A1C be? For their diet, what should they do to improve weight loss? Okay, for cholesterol, what should they keep their cholesterol? Which one of these teaching, when the patient says these things, which one of these statements are correct? All right, do they say, might keep my blood pressure under 150? Well, that's not good enough. It needs to be 130 because they could be walking around the 145 systolic, right? They take aspirin only when they have pain? No, you take aspirin every day, right? All right, so where do you want to go next? You want to continue with ASCVD?
Sure.
Sure what, ASCVD?
Yes.
All right, so right now I have about 7 questions on ASCVD, and other ones have like 12 and 10 questions. So it's up to you.
Let's do the one with the 12 questions then.
All right.
Which category is that?
So pretty much most of them are going to be 12 questions, except like 10 to 12 questions, except for CAD and ASCVD. Those ones have like around 8 on the low side, 8 to 10.
Mm-hmm.
So, because CAD, really there's a little big section there we're going to talk about in MedSurg 3 or 4th semester for some of you. That's how to manage an MI. There's a lot of stuff there with how to manage an MI. We kind of skip over that. We have to know the precursor, CAD, angina, unstable angina, and know that the complication is ACS. But as far as management of ACS and all that stuff, that's all 3rd semester, or MedSurg 3, 4th semester, as far as identifying all that stuff. But we have to know chest pain. We have to know what chest pain looks like, if it's chest pain from unstable angina or it's chest pain from just an upset tummy, right? So the patient needs to be able to report those symptoms, and we have to be able to recognize those things to tell them to call 911 or we have to call the doctor, and we have to know what to do about it, right? And what do you do about it?
Depends if they can walk or
Crushing chest pain that's non-provoked, that's radiating, that's pressure and not positional, right? These are all things that make it cardiac chest pain. If it's carrying chest pain, something else, right? Good. So nitroglycerin is the one that you have to know all about nitroglycerin. That's great teaching, right? Make sure it's not expired, make sure it's not in a glove compartment, make sure it's not at home, right? So it needs to be on the person, cool place, not expired. Make sure they don't take it per rectum. Make sure they take it per mouth and not swallow it.
Right.
Make sure they take it under their tongue. So that's really good teaching. It's a really good good question, right?
Right, and they should call 911 if it doesn't go away, even after they take it once, right? If
Yeah,
they
so if
still
it's
feel
not,
the
if it's
symptoms.
improving, they can take it again. It's improving, but if it doesn't go away, yeah, they need to call 911. Doesn't go away, or it gets worse, right? Or it stays the same. It's time to call 911, or it's time for us to call the MD.
Unless they're chest pain free.
Correct. They're chest pain free after nitrates when they got 3 rounds of it, right? How long should the whole process take them?
No more than, because it's 5 minutes in between each dose, so no more than 15 minutes, right?
Correct. Yeah. So you should be done in 15 minutes to decide whether it's time to call 911 or not. Okay. Yes, we want to recognize symptoms of complications and how to manage it, and then the complications of ACS in of itself are what? How do you get what are complications of ACS? Or let's say worst case scenario of a STEMI or NSTEMI.
An MI.
An MI. Well, that's an MI, but what's the complication of an MI? This guy right here, right?
ASCVD, CHF, yeah.
CHF. ASCVD cause. So if we're doing causes, right? So if you like grab the table here. Oops. Right. So if we're doing a table for ACS, right? So we want to make sure we know causes, ASCVD, right? Causes, hypertension. Causes, diabetes too. Okay. And what other stuff you have? Obesity, metabolic syndrome belongs in CAD. Metabolic syndrome belongs in ASCVD. And that stuff is easily testable. It's an easy SATA question because there's like 4 criteria. Which of these criteria are metabolic syndrome? Which of these criteria does the patient know how to avoid, right? How to knows that they're on the right track. Okay. And then pharmacologically, these guys are on statins and aspirin too, because ASCVD is a big, big part of it, right? Statins and aspirin, right?
Yeah.
But on this guy, already high risk if they have CAD. But we got nitrates, right? Nitroglycerin. We want to know all about nitroglycerin. You can put it here to make your table bulky, or you can make another table just right over here for nitroglycerin. Instructions, complicate what to teach, all that good stuff, right? And then teaching, same thing. Complications, well, we got CAD, ACS. And what is ACS?
NSTEMI, STEMI, and unstable angina.
Good. Unstable angina. We got some STEMI. All right. So we have to be able to recognize what those look like, what those symptoms are. We have to know what the symptoms of cardiac chest pain, not just aortic aneurysm pain or pericarditis pain. That's not what we're looking at. We're looking at actual cardiac chest pain, not GI chest pain, but which is just like below the chest. We want to make sure we recognize cardiac chest pain. We also want to make sure we know what angina is versus unstable angina. Okay, because unstable angina is a complication, right? If you like colors, I mean, we don't have time today to do all the colors, but make sure we know that that's a complication, right? If you like to put all your complications in red, more power to you. Okay. So we know
between,
the difference.
Oh, sorry. Between NSTEMI and STEMI is I just off the top of my head, I just can't remember right now what the difference would be. Good. But I know they both have elevated troponin levels, and then the EKG looks different. I know that, but I can't remember.
If you can't remember the difference, teach it to each other. That's the best thing to do is teach it. That way you know the difference and people can check your work, right? And if that doesn't work, you just put a table together, right? So we got 3 things, right? So what about troponins? What about, or let's put symptoms, right? Like the chest pain quality. What about the troponins, right? What about EKG changes? And you can always put another EKG there. Where's my little shortcut? There it is, right? EKG changes. If you don't know what a STEMI looks like, just Google STEMI, right? So let's put STEMI here. STEMI, and let's drop it in. Right, so that's a good STEMI right there. Let's drop that guy in. Okay, bam, there's a STEMI. Okay, it's a row above, because that's like worst case scenario, right? Because we have our unstable angina. And you can put in parentheses angina so we can see the differences, right? Oops, STEMI. And autocorrect, there you go. Okay, what are our symptoms? What's our difference, right? And what's nice sometimes is to put all, right? Because each one of these has cardiac chest pain. Instead of copy and pasting it every single time, cardiac chest pain, cardiac chest pain, cardiac chest pain, right? And you can make a table for chest pain and differentiating what the different chest pains look like. Okay, you can just put a row called all, and this is the characters of every single one. That sometimes applies. Okay.
With stable angina, is that just specifically like angina that just isn't changed throughout the person's day, whereas unstable is increased pain or new onset chest pain? Like, what are the actual differences? Because like when I read up about the stable angina, it just says that it can happen upon exertion, but it's the same for unstable.
So stable angina is cardiac chest pain with exertion, right? This is at rest. That's the key difference.
Okay, thank you.
And what is exertion?
Standing up and going to the mailbox, like you said.
Yeah.
So it's just not
when your
rest.
heart rate is
Not at
elevated.
rest. You're just watching TV or watching Amazing Race, and all of a sudden, it's getting you excited, and then you get chest pain. That's cardiac, not just Pepsi from the Doritos and Diet Coke you're drinking, but actual cardiac chest pain. Okay, so going to the bathroom, right? Just our patients getting up out of bed, going to the bathroom and back, can be chest pain with exertion, right? That can be stable angina, and then they just rest. If it doesn't go away, time for some nitrates, right? So you can put over here how to treat, right? Insert row, column to the right, right? Treatment, right? How do you treat these guys, right? So unstable, we're gonna do nitrates, and then we're going to STEMI, we're going to cath lab immediately. Cath lab in 60 minutes. Okay, and STEMI, cath lab, whenevs, okay? And it depends. Sometimes they don't need cath lab, but. All right, so you still want to do ACS, or you want to go on? Sorry for that tangent.
Can you do valves?
You want valves? Yeah, so valves has about.
After valves, can we do CHF? Because I know it's like huge.
Yeah, CHF and valves have about 12-ish questions each. Okay, so carditis has about 10. The ones that have the least amount are probably carditis and our ACS and ASCVD. Everything else has a good 12 questions, sometimes up to 14 questions. Okay, so yeah, valves. So what do you want to know about valves? So again, I always think of things in tables, so we can start with that. I like to sometimes put a one that says all valves, because I want to know what's different, because things that are different are things that are tested on, right?
Right.
I probably could have kept some of those things are probably the same, right? So you can just put all your different valves, right? So you can group it, you can be savvy. You can put another table, let's put this guy. You can separate it by systolic versus diastolic, right? So our systolic murmurs, we've got our diastolic murmurs, or I don't know, that might get a little hairy. But you can make another table that compares systolic versus diastolic, right? So you can easily, know exactly what's going on. Diastolic murmurs and what it looks like and what to expect and such. All right, let me know where you want to go with valves.
So right or left? Wait.
As far as symptoms,
I don't have my notes in front of me.
Well, that's good. That's actually the best way to study is without your notes,
right?
Because that way you're putting the information from your brain out in the universe, either it'll be on paper, teaching in front of someone else, or you're actually telling your dog how valves work. You're verbalizing it. You're forming the literal synapses, right? Just like a concert pianist does not read the sheet music every single day up into the concert day and start playing the piano. No, they actually have to form the synapses, the muscle memory, and all those things beforehand. Okay, so you can't just keep reading and reading and reading. You have to practice, whether it be in-class questions or verbalizing, teaching. Teaching helps the best because I learn things like 15 things every time I lecture in front of you guys. I learn like 10, 15 things I never knew before. Just, oh, I just made a connection. Oh, just made another connection. That's why this is that. So you form an immense amount of connections when you teach.
Yeah.
Okay, the symptoms, yep, CHF, right? And as we right versus left, depending on where the valve is, depending on valve location. Okay, so in these guys over here, we can describe it. All right, so we got mitral, and we got our, I guess I do need that other column just so I can separate this guy out. Okay, so okay, stenosis versus regurg. If you don't know the difference, let's make another chart, right? What's stenosis, what's regurg, right? So mitral stenosis, mitral regurg. Well, first you got our MVP, or prolapse, right?
Yeah.
Right, and then we get regurg. That's the other one that has a little extra bit to it, all right? And we got our mitral, and we got our aortic. I probably put aortic first because that's the most serious. Aortic stenosis being the most serious, all right? And we got regurg, and we can fill in the rest, right? Our other two valves. Okay. If you want general information, if you want some more stuff, like is it semilunar or AV valve, all that stuff, you can put that over here too. All right, so that's what we got going on. So where do you want to go with this? I forgot what I was going to talk about.
The differences.
Yeah, so you can even color code this. All right, so let's make some color code. Let's make mitral valve. What do I think of mitral valve? Maybe light purple. I don't know how to mention that. Anyways, so yeah, so differences. So as far as symptoms, all right, let's put a thing here. Let's make it look a little neater. Where's my symbols at? Special characters. Let's put a little bullet point. I don't like the way when you actually do a bullet, it actually throws everything off. Okay. Oops, see, it does that. I don't like that. Let's make it look neater. Okay. So more murmur equals more what? Equals what? Oops, more blood. I give you the answer.
More blood.
More
blood,
cardiac
yeah.
output.
Mm-hmm. And usually more what a murmur is, right? If you just define it, right? If you put like a general thing, a murmur is just turbulent blood flow. And more blood flow, more turbulent blood flow means more sound, right? And that's accept, right? A little asterisk there. So that's which one's the accept for more blood, more murmur.
Prolapse? No.
I don't know.
No, we talked about it.
Yes,
Is it
mitral
aortic
prolapse.
It's a prolapse, yeah.
Yeah.
So
You would have more blood with stenosis and the regurg, both.
yeah, more blood equals less
Process
murmur.
of elimination on that one.
So that's the exception, right? And then another feature of valves, let's put this guy here, I don't want red anymore, is that more afterload equals more murmur, right? And we put a big asterisk there because which one's the exception? Where's my colors at? Let's put blue.
Aortic stenosis.
That's ugly blue. Good, aortic stenosis. Okay, more afterload equals less murmur. Okay, so those are our exceptions. And then of course we're gonna, under that, I'll probably put my regular stuff, right? Which one, so let's just do which ones have left heart failure.
Mitral valve.
Yeah, mitral. Okay, left CHF. Left and right. CHF, all mitral, right? That's all mitral. Stenosis, prolapse, regurg, that all has left and right CHF. Our stenosis and prolapse, they also have another unique finding, which is what? All of our mitral stuff. Some more than others, but they have this unique finding, which is what? Besides the CHF symptoms. Besides more blood, more murmur, more afterload, more murmur.
Pulmonary issue.
Well, that's left heart failure, right? And if you have to define left versus right heart failure, that should be under our CHF section, right? left versus right. That's an easy table, right?
Mhm.
And you want to put like another causes because the causes are important as well. And HFPEF versus HFREF as far as causes. What are my causes? I can differentiate those. That's a really good static question. Or a multiple choice question. Which one of these is HFPEF? Which one of these is HFREF causes? So yeah, so your mitral murmurs, mitral issues, they have this unique symptom. No other valve has this symptom.
JVD?
It radiates to the axilla.
Scallop.
Dysphagia.
They're holosystolic.
Put this guy right there. There we go. Hoarse voice, right?
The
Hoarse
gallop, you're
voice.
right.
You have a dysphagia, right? That's pretty much all of our mitral stuff. I mean, there's other ones like mitral stenosis for sure is going to have it, but prolapse wouldn't have it because the complication of prolapse is regurg, right? Mitral regurg. But regurg for sure is going to have, that's going to dilate that left atrium really good. Okay, so that's looking at the differences, right? Interventions. What are some interventions for valves?
Not smoking.
There you go. Just do not smoking. Just do your ABCs, right? That'll work because that'll fix the CHF. That'll fix the underlying cause, right? That's usually the answer all the time, but that's not going to be a test question because underlying cause is not specific enough, right? So we have to figure out the underlying cause, right? So let's shoot some causes out there. What are some causes of valve stuff?
Rheumatic fever.
Rheumatic fever. What else?
Endocarditis.
Endocarditis. So you put IE. If you don't know what IE is, go down to your carditis section and define IE, right?
IV drugs.
IV drug abuse, right? And you can put the one that it loves, right? It loves right heart failure stuff. So put it especially down our right stuff, especially tricuspid, right? But IV drug abuse can attack anybody, any valve. IE can attack any valve, but it loves the mitral. Right? And just good old age, right? Age will do it. And
Congenital malformations.
CHF will do it. What kind of malformations? Congenital?
Congenital.
Yeah, that's more going to be pediatrics. When you get to pediatrics, you'll learn about all the congenital heart defects. You'll have all the nightmares of valves all over again.
Yay.
Yep. So, but CHF, any kind of physical change, which is pretty much age and CHF, right? That's going to dilate things out and cause our valves to open up more and become more regurgitant. The aortic stenosis happens with age and calcification. So you put that under stenosis, calcification with age. Okay, in case I didn't know that, in case I'm not gonna remember that in the future, I can write it down. All right, so yeah, causes. Back to nurse interventions. What are some nurse interventions you would do?
Keep the head elevated and oxygen if needed.
That's not a good one, but good. That's always the right answer. Head elevated, apply oxygen. What else? There we go. That one works better. Okay, and put that here, right? Make sure we assess it, or if I don't know what that is, let's make a table down here, right? Where I compare auscultation zones. And I can put I'll make a table, of course, but you can look better. But either way, I can say put auscultation zones here, right? As far as signs and symptoms, maybe, or nurse interventions, I could put down auscultation. Where do I auscultate stenosis? At where, right? You could put stuff, right? It wants to tag somebody, I don't know why. All right, put the ICS, MCL, okay? Or which is the mitral zone. Imagine that. Mitral valve stuff is a mitral zone, right? And each one and where that's at, if that's something new to you. I mean, we did learn it first semester, but it's still, if you want to be complete in OCD, more power to you. Okay, but you're auscultating in the right spot, right? So as far as auscultation or identifying murmurs, right? There's 3 steps. What are your 3 steps? A hint is auscultation zone. That's going to tell you where the murmur is. If I auscultated best at the tricuspid area, it's a tricuspid murmur. If I auscultated best at the pulmonic area, it's a pulmonic area, murmur. At the mitral area, guess what? It's a mitral murmur. Now I have to know if it's mitral stenosis or mitral regurg. And how do I differentiate that? What's step 1?
Systolic or
Or diastolic.
diastolic.
Systolic or diastolic, right? If I know what that means, I'm not going to burden my table up here. I'm going to come down here, my systolic versus diastolic. All right, examples. Let's put another one. Let's define it, right? So I don't know what that means. So systolic, and you can put pictures. S1 to S2, right? S2 to S1. That's a systolic murmur, that's a diastolic murmur, right? If I don't know what that means, I can just put S1, S2. All right, so I have, instead of the red arrow, that's where my systolic is, right? That's where my murmur happens. Between S1, S2, that's a systolic murmur. All right, let's crop that, or like crop that. Crop. So I don't get confused, all right? That's a systolic murmur between S1, S2. Oh, look at that. There's a win right there. It already has which ones it is, right? You can put your mnemonic, right? Your arms and parts. Aortic regurg is, or vice versa, right? Aortic regurg would be whatever, right? So you can put your mnemonics in there too. Tricuspid stenosis would be diastolic. Pulmonic regurg would be diastolic as well. Okay. All right. So are we good on valves? You want to keep going on valves? We got about 30 minutes. Well, let's just finish our thought here. What's the 3rd step?
Maneuvers.
Maneuvers, right? We're maneuvers. And when I'm auscultating best at, I'm under my auscultation zones, I'm going to put some notes here, right? Auscultate how? At the correct zone with the correct what?
Part of your stethoscope.
Yeah, with, which is called the what?
The bell.
The bell.
Or
Osteo with bell, right? If you know what a bell is, drop an image in there. Okay? Osteo with bell and position on
The left side.
Left
the
side.
left side. Okay? If I don't know
And
my
I read something like specifically like with the mitral, if you even have the patient sit forward, what is the difference between them sitting forward, making the heart, you know, come out more versus putting them on the left side?
So positioning is important when you're talking about like raising the legs or squatting and such. That can improve your murmurs or make the murmurs more quiet, right? And that's what this is: more murmur, more blood. So that's your maneuvers here. If you don't know what your maneuvers are, you can make a quick table on what my maneuvers are and what it would do, right? Because maneuvers are either going to increase blood to the heart, or they're going to decrease blood, of course, or they're going to increase afterload or decrease afterload. And we know if it's increasing afterload, well, that means it's this murmur. But on the exam, I'm going to give you 2 of these. I'm going to give you 2 out of 3. I'm not going to give you just 1, and you have to figure it out. If I give you just 1, I'm probably going to give you an auscultation zone also, and some other, maybe one of these guys as well, right? Because this tells you it's systolic or diastolic too, right? All right. You still want to hang out with valves, or you want to go with CHF? Do you want to nix CHF? What do you want to do?
CHF, please. I guess just mostly focusing on like left and right sided differences.
Okay.
Just trying to think back to like what was most important.
Mm-hmm. So as far as our segue from valves, complication of valve disease, CHF, right? And CHF causes valve disease. So that's a catch-22. That's a downward spiral. Okay. So again, I'm gonna put this up here. We can do that stuff. Right. So if you want to do like all CHF, right? Versus HFPEF. Let's put HFPEF first because that one's kind of weird. But HFREF is the one that we know and love as CHF for the last 150 years. That was CHF up until like 2008. Okay.
So sorry, just to PEF was the one that's asymptomatic for the most part.
Yeah, it's basically, he found it on the echocardiogram when it was invented in 1986. So I was like, oh, look at that. They have HFPEF. Their ventricles are hypertrophied, right?
Yes.
Hypertrophied ventricles.
And that just
And they
means
have-
enlarged, right? That's just enlarged.
Yeah, you know what that means? This table is your table. You can put stuff in there. When we get to neuro on Monday, we're going to be throwing a lot of Latin and Greek at you. So you can definitely define those things, right? So hypertrophied, and then we can have, EF greater than what?
45%.
5%. And this is EF less than 45%. What if my EF's 45%? What do I do? Which one is it? I'm not going to do that to you. I'm going to give you an obvious EF. Okay. And really, these percentages are estimated. There's no exact. I mean, maybe nowadays they have like a Cadillac of echo machines, and those maybe be able to give you an exact number, but it's always estimated by cardiology. They just kind of look at the screen for 1.5 seconds and give you an EF. Right. So diagnostic tests, echo. Right. Echo is up here too for CAD diagnostic tests. We're doing echoes to see if they have MIs, right? Diagnostic tests. What are some other diagnostic tests for CHF?
EKG.
Yeah.
Just do an EKG because causes were CAD-ACS, right? And let's rule out, if you don't know why you're doing an EKG, I always try to fill out all my tables with rationales. Guys, that's how you learn things. Otherwise, just memorizing a phone number. And you can only humans can only memorize about 10 digits at a time. That's why phone numbers are 10 or 9 digits. 10 digits, right? So you can only remember 10 things for the test. Well, you got to know rationales, right? You don't memorize the street address for in and out. You know exactly how to get there, right? So you don't memorize it's on 440145 North Avenue I or whatever. You memorize that it's on, that this is what's, how to get there. Take the freeway to this, to that, to get there, all right? So rationales are very, very helpful. All right, so rule out ACS because that can damage my heart and therefore I have. And why, if you don't know why this is, right, causes death of muscle. Okay, so yeah, echo, EKG, what's another diagnostic test?
TTE, TEE.
That's echo, right? TTE. And then versus TEE, okay? And why would you do a TEE? Everybody gets a TTE, but only some people get TEE. Who gets a TEE?
To confirm the issue, to confirm the.
What's the issue?
Dilation.
No?
To confirm vegetation.
Vegetation. So we were looking for valve stuff, valve vegetation with TEE. So in our valves here, we're doing TEE, then TEE if vegetation. Okay. So it makes sense if valve problems cause CHF, right? We should probably be looking at echo first to see what their valves look like. If they have like fulminant mitral stenosis and there's no vegetation, no need for TEE. But if there's vegetation, they're an IV drug abuser, they're what else? They have all the complicated rheumatic fever. They have they're 96 years old and they have a history of CHF. Well, shoot, let's do an echo. And then if that echo shows all that vegetation, now it's time for TEE. If you can't remember this part right here, go ahead and duplicate it. No, that's not no points off for that. All right. So stress test would not be for CHF. Who gets a stress test?
Cardiac patients.
That's up here, right? For diagnostic test, echo, stress test. Know your prep, know how that works, right? And then EKG, rule out ACS, and what else do we do for CHF for diagnostic test? Applies to every CHF.
Chest X-ray.
Do a chest X-ray to tell you stuff. I didn't really get into that too much, but what else?
ENP.
EMP. the pro-BNP versus BNP, right? And then pro-BNP we do, and if it's normal, probably HFPEF, but if it's abnormal, and we want to know our abnormal PBNP.
Would an arterial blood gas be included in the labs too?
Yeah, you can do chest X-ray, ABG, chemet CMP, coags, all of that stuff. But we want to kind of differentiate the big stuff, what's going to tell us stuff. An X-ray in real life, yes, X-ray is going to tell you if they're in fulminant pulmonary edema or not. That's going to tell you if they have CHF. All right, ABG is going to tell you how they're oxygenating well. Complications of every CHF ever, CHF exacerbation, right? Yeah, I probably make another table for my complications. Other stuff, right? CKD for our final. Okay, so what other CHF stuff? So we want to know your causes, know which ones are for all CHFs, right? Which ones are just PEF, which ones are just REF. That's a really easy multiple choice question. Which one of these is REF, an REF cause? Which one of these is a PEF cause? Which one of these is both? Okay, if you don't know what preload, afterload, contractility are, make a table, right? Or write it out, teach it to each other, right? Preload versus afterload versus contractility. And then you can differentiate which one is, what's our goal with HF-REF? What's our goal with CHF exacerbation? Which one are we trying to reduce or increase? What else? With medications, it's a big one. Which one of these reduce preload? Which one of these reduce contractility? Which one of these reduce afterload? So when you're doing meds here, right? And our meds are going to be, you can put our meds up here and like which ones are the ones they use. Because these guys are all about the hypertension, fixing hypertension, right? And these guys, we're going to fix other stuff. Okay, so nursing diagnoses, you could throw that in there if you want to throw nursing diagnoses. Nursing interventions, what do you teach for CHF? That's for anybody, right? Teaching, when to call 911. For CHF, who do you call? Or when do you call? You call the Ghostbusters, but when do you call?
When you've gained over
Gain weight, how much weight?
1 kilogram.
1 kilo, 2 to 3 pounds, right? That's in a day or in a week. It's X amount, right? So what about, what other teaching would you do?
To weigh every day.
Weigh every day, and if you gain weight, wait. What else?
Low sodium diet.
Yeah, so it's ABCDEs, right? That's all important. What else? What's like specific CHF?
Reduce fluid intake.
Fluid intake, fluid restriction sometimes, yeah. And we'll talk more about fluid restriction and CKD, how to tips and tricks for that. What else?
Restrict exercises.
Restrict exercises? That's kind of under E, right?
Yes,
Exercise.
they will have
Exercise as tolerated, or if you can, 150 minutes a week. What else? When do you call 911? Not when you're exercising, but when you're
Chest pain. Shortness of breath.
short of breath, right? Short of breath when?
at rest.
At rest, right? There's another at rest. What's a third at rest? It's a symptom that you have at rest. So you got short of breath at rest, chest pain at rest. What else at rest is a symptom of something?
Palpitations.
Palpitations. Leg pain at rest. What's that called? That's a fancy name.
EAD.
Claudication.
No.
I mean,
EAD.
At rest.
Critical limb ischemia.
Critical limb ischemia is pain in the legs at rest. Okay, so yeah, you want to know your stuff here, right? If they can't eat, right? Poor appetite for a day, time to call 911. If they have, short of breath at rest, chest pain, for sure, we call 911. Okay, all right. Any last minute questions? Or we got still got about 15, 20 minutes. What else do you want to go over?
Got it on. There's a
Which one? You guys cut out, or someone who was talking was cut out.
Sorry, that was my daughter. I was off mute.
Okay.
Did you guys go, sorry, I got off for a minute, but did you go over PAD?
No, and we just did, that's a good segue. We kind of segued into it. You want to do PAD?
Sure.
Yes.
Let's grab this one here. So we just described, where's my PAD at? There it is. We just described some symptoms, right? We got, let's grab my little bullet point here, my superior bullet point. Right? So we have at rest, right? With exertion. And we have pain, critical limb ischemia. Critical limb ischemia is pain at rest. Okay. What is it with pain with exertion?
Intermediate
This is
classification.
leg pain. We should define non-cardiac, I don't know, leg pain. It can happen in your arms too, but leg pain is the most common. So that's called intermittent claudication, right?
Mm-hmm.
What is pain on exertion with the heart? Chest pain on exertion, what's that called?
Unstable angina.
Unstable.
No. Stable angina, that's angina. Angina is pain with exertion, right? Pain at rest is unstable angina. That's the difference. That's the only difference. Okay. All right. So we got those symptoms. You can put other stuff on there, like kind of maybe there might be a little overlap here because over here we got gangrene, right? We want to know differences between a arterial ulcer and a venous ulcer. That's an easy static question or easy question to differentiate which one of these is a venous ulcer, which one of these is a arterial ulcer.
Mm-hmm.
Put a table there. All right. So you can put arterial venous versus venous ulcer, but I already know. Okay, so you can divide it out uniquely. You can just put symptoms, whatever you want to do. So arterial ulcer, or just put both. Arterial ulcer, venous ulcer, right? They both have pain, but pain at what? There's only very few things that are like overlap. I think like the fingernails or the nails are the only ones that get thick, come with both. There's not many other things that are similar. There's literally a lot of good differences. So what about the pain? When do you have pain with arterial ulcers?
When you elevate,
Yeah, with elevation, right? And that means it's better with rest, with a dependency. And what is dependency? When you live with your parents till age 25?
When you lift it, is that?
No?
you put it down.
It's pain with elevation, it's better with elevation. That's not right.
Put your legs down.
When
Your
it's
feet
below the
should
heart.
be dangling.
Dangling, yeah.
Yeah, dangling below the heart, right? More gravity, more blood flow. That's what's going to improve it, right? So I talk about more blood flow. That makes me think of ABPI, which sounds like a 1980s cop show. What is ABPI?
Go brachial pressure index.
Mm-hmm. How do you do an ABPI?
What's the angle pressure?
You take the A and then you take the B, right? And is it the systolic, diastolic, MAP, pulse pressure, mean pressure, CVP, JVP, which one do you take?
Systolic.
Systolic. So it's systolic of the A, systolic of the B, right? All right, so venous ulcer. Just finish this thought. What's the pain like with venous ulcers?
Pain with the dependency.
There we go. Just the opposite, right? Pain with Dependency. Better with elevation. All right, you can do other stuff on there too. I don't know if the both column is really gonna help us that much. Just delete that. But there might be some that's the same, right? So we pain, you can do pulse. Looks like we're doing 6 P's right now. What are our 6 P's?
Powering, pulse, power, polar, pressure, parathesis, and paralysis.
Right? And polar, fancy word, hypothermia. All right, and if you know what these mean, you can just define them right here, right? Pallor, white, pulse, pulse. And how do you measure a pulse? It's for all of them. How do you measure a pulse?
Fetal pulses?
Bilaterally. Right, so which one's white?
Arterial.
Good. White, right? Pallor. And this one, what's venous ulcer?
Red.
It's red. Okay. It usually also has hemosiderin deposits. What the heck is that? And. Okay. There we go. Okay. What else? All right, and then you can put other features down here. Okay. Such as whether it's swollen, edema, or no edema, right? All right, so that's PAD. Treatment-wise, that's where everybody gets hung up because you have now we're introducing coagulation, coags and stuff, right? We're giving all kinds of antiplatelet medications, which should be a duplicate from up above, right? Up here with CAD, we're talking about our treatment was statins and aspirin, right? And we're doing Plavix or clopidogrel. It's a Cagrelor after treatment. Okay, stenting, cath lab, etc. But we're going to be talking about clopidogrel and aspirin down here with our PAD. What's the one medication that's for PAD?
Cortisol, cortisol. I can't pronounce it.
Well, it's not what you said. Cilostazol. You said the right answer, but you're trying to say you're saying bad words. So I was going to say not that one. All right, so cilostazol, that's a one disease medication. So you better know because that's the one disease that it's for. So you should know that medication, right? And then we got other stuff too. We could be doing DAPT, which is aspirin plus Plavix, the brand name. No brand names in the test. So what's the brand name? What's the generic name for Plavix?
Clopidogrel.
Clopidogrel.
Sorry.
Okay, aspirin, clopidogrel, right? We could be doing that for them. Okay. Sometimes they're on. So we got antiplatelets. I'm kind of making this table beefy. I don't like doing that. And anticoagulants. So I probably split this into another table so I can see clearly which one's which. I can make an antiplatelets table, an anticoagulants table. And then on the test, I can't remember which one's which. Well, geographically, I can remember, oh, I did antiplatelets first and my anticoagulants are way down there. My anticoagulants, that was my warfarin, heparin, 10A inhibitors, and dabigatran. That's what that was, right? You can put them here, right? Your 10As, your dabigatran, right? Your warfarin, your hep, right? But if I don't know what they are, I need to know how they work, which ones to, how do I reverse each one, right? Each one has its own reversal agent, all right? So which one do you use andexanet for?
For 10A inhibitors.
10A inhibitors has 10A in the name too, all right? And Dexa, 10A, right? Which one do you use adarucizumab?
Dabigatran.
Dabigatran. What's the reversal for heparin?
Protamine.
Protamine sulfate, right? So you want to know your reversals, you want to know your teaching for each one, right? Especially your warfarin versus heparin, what the differences are there, but also the teaching. Every single one of these antiplatelets or anticoagulants, doesn't matter, has what side effect?
Bleeding.
Bleeding. So you better know all your signs of bleeding, so you can recognize that and let somebody know about it. And also you want to know what to teach the patient, right? Whether you use an electric razor or a straight razor, whether they increase their green leafy vegetables or not, whether they get pregnant or not, right? Whether they have contact sports or not. So I know those kind of things to differentiate. All right, so what else? So then 6Ps, DVTs. This is another kind of under the PAD section. I kind of put it there, but it is vasculars as the venous side of things. But one of those complications of DVTs is our venous ulcers. That's where we're going with that. All right, so reversals, DVT teaching, DVT assessment. What does DVT look like? What's the antiplatelet? What's the anticoagulant? Okay, so we've got about 5-10 minutes, unless you still want to keep going. Might be falling asleep with me just talking.
Miss Arcelli mentioned I don't know if I'm wrong, but I think she was calling it PVD instead of PAD. I don't know. Did she do that? I think she did. I don't remember exactly.
Yeah, they differentiated it like 10 years ago as far as, because it was confusing people. They called it PVD. People couldn't figure out if it was arterial or venous. It's not that hard, but the V, you think, oh, that's venous. So they make it PAD and venous insufficiency. They made it super clear now. So there's no confusion. PVD is just an old term. It's not wrong. That's just an older term for it.
Okay, so
you have PAD, which is PAD stuff, and then we have venous insufficiency. Under that, we have just straight up varicose veins. We got tortuous veins. We have all kinds of other venous insufficiency problems, including DVT. DVT is the big one and the most deadly one, right? What happens? Why is DVT deadly?
They can go to the lungs or the brain.
To the lungs of the brain, right? And also we have, what was I going to say about that? How do you prevent that?
Medications.
Anticoagulant.
No smoking, no smoking, especially with contraceptives, oral contraceptives.
No long trips, right? Going to France, going to China. That's probably not a good idea if you have a history of DVT or you're pregnant or you're smoking. Don't smoke on the plane either. So all those things would put you at risk, right? What about the hospital? People aren't flying in the hospital or smoking in the hospital usually. So how you
They need to be using their ICDs.
Not ICDs, but SCDs.
Or SCDs, sorry.
Implantable cardiac defibrillators are for CHF, and they should be using those for lethal arrhythmia. But yeah, SCDs, right? SCDs, and what else? What else do you do to do VTE prophylaxis? Say again?
Compression socks.
Compression stockings, or which is
Range of
SCDs,
movement.
but what else?
Range of motion
and
exercises.
moving is good. What else? What pharmacological prevention management is there for DVTs?
Lovenox.
Yeah, Lovenox, but Lovenox is not going to be in the test. What is?
Enoxaparin.
Enoxaparin. So if we're going to put medications, they're going to have to be generic names. All right, so that's DVT, PAD. Any other sections to really briefly touch on?
She had mentioned knowing about the cor pulmonale. We didn't really touch on it though, but just what I had looked up was basically like pulmonary hypertension leading to right-sided heart failure.
Yeah, so cor pulmonale there's two big causes of right heart failure. So if we're putting this in here, right, this one has left and right. This is where we have left heart failure, right heart failure, right? And under REF. Okay, so if we're looking at this one, right heart failure is due to cor pulmonale. Where's my upgraded bullets here? All right, so right heart failure, most common cause is what?
Left-sided.
Left heart failure, that's it. If they have left heart failure, you're going to have right heart failure if you don't get it managed. Okay, that's the most common cause. But second most common cause by default is cor pulmonale. And guess what? If it has a lung diagnosis, it can lead to, usually chronic stuff can lead to cor pulmonale, right heart failure. So that'd be like your COPD, pulmonary fibrosis, COVID, whatever pulmonary you can think of, cystic fibrosis, all kinds of stuff. But big ones, COPD, that's very common. So if you hear COPD and heart failure, you're thinking it's someone that has probably cor pulmonale, right? And they have right heart failure. So we can differentiate left versus right? If you're savvy, you can do 2 rows and merge and all that other good stuff, but you can differentiate right heart failure and left heart failure. Because cor pulmonale has right heart failure, does not have left heart failure because cor pulmonale was a lungs fault. Now in real life, do people with cor pulmonale also have left heart failure? Yeah, but we're not going to get complicated because cor pulmonale patients can also have hypertension, which can cause left heart failure, or they can have MIs and such. So there's a lot of overlap in real life, but right now we're trying to make you distinguish the differences. Just pure cor pulmonale.
And are you gonna also give us like a little blueprint like last time, like at least just to let us know how many of each? I know you kind of told us, but
yeah, it's 8 to 12 on each section of these sections here. So like ASCVD has 8-ish, 8. And then our CAD has 8-ish. And there's overlap, right? So even though I say 8 here, there might be a CHF question that has ASCVD answers in it. All right, so it's probably 12-ish, 13-ish maybe. Valves, I think has 10-ish or 12-ish. We'll put 11. Okay, what else? We got topical protection zones. Carditis has 9-ish, I think. Okay, then we got hypertension. That's going to have a 10-ish, I think. PAT, about 12-ish. Or let's put like 11. All right, so that's 11, 20, 30, plus these guys here, 41, 54, 62, and 70. So yeah, ish, which is 75 questions. Okay, any last minute questions? Was this helpful or more scary now that it's only 24 hours away?
No, it was helpful. Me knowing, since I don't have my notes in front of me, I know what I know and I know what I don't know. So that's good.
Yeah, so I was going to do it yesterday, but I was out, and then I'm still working on the exam and such too, like finalizing it. All right, and that's all for now, I guess. If you don't have any other last minute questions, again, this is located in the Exam 2 study tools. If you have other useful stuff, you've already made a cool chart, you drew the valves, like one of you is an artist, go and upload it here for other people to see too. It might be helpful. I'll get some rhymes from someone in my clinical group. We'll upload their rhymes there. Their rhymes are already there in Exam 1 study tools. So we got exam, I thought I put them there. We should put them somewhere else. Either way, we'll upload those.
Oh, sorry, your updated chart from now is going to be up there too?
It's right here, Exam 2 review.
Oh, okay.
Was it? Christina was already in here. She's already there, looking at it, already editing it probably. Okay, so that's there for you guys. Okay, and that's how I study for exams as well. And as I'm doing in-class questions, as I'm going through lecture or after lecture, or even during lecture maybe, we can go through and make tables like this to try to differentiate things. And of course, you can asterisk things that I said. Oops, someone made it all pink. Okay, so you can asterisk things that are he said in lecture that's a question, right? So you can maybe highlight things that are questions. Have your own system. Okay. All right, any other last minute questions? Speak now or forever hold your pieces. All right, so if you have a question afterwards, you can always message me. Okay. And then this will upload to
Thank you.
the cloud, and then I'll post a link once it's done.
Thank you.
All right, you're
For
welcome.
taking the time.
Mhm,
Thank
you're
you.
welcome.
Thank you.